And can I introduce Meredith Borland, who is Department Lead for Perth ED, and she's going to talk to us a bit about Wheeze.
Thank you for inviting me, Damien, for another talk. And this is about a topic that I'm quite passionate about. And I'm going to talk about the wheezy child, and that treatment is simple, isn't it? So, before I launch into discussing the case, I'm going to start off just by setting some definitions. It's always good to know what you're talking about. I'm not talking about bronchiolitis. I think we've actually heard quite a lot about bronchiolitis so far. And so children aged under 1 who wheeze is bronchiolitis. We're not talking about that. We're talking about preschool wheeze in children who age between 1 and 6. And I know preschool, depending on which area you come from, they might have already started school by 6, but that's the definition. Okay, so we're going to start with a case, and I haven't made a spelling mistake. That is sometimes how you spell Jaxxon in my area of the world. Jaxxon is 2.5. He comes to the emergency department at 5 o'clock on an early winter's night. He presents with a cough. He's got noisy breathing. He's had a recent ERTI, and he goes to childcare. There's no pets or smoking, and no significant other past history. When you have a look at him, he's a bit grumpy, but clingy, but he looks otherwise okay. And he's got a cough quite a bit, and he's also sounding wheezy from the end of the bed. His observations are listed there. They're not particularly exciting, but he does have intercostal and subcostal indrawing, and he's got widespread wheeze across both sides of his chest, and he has a red throat, and he has profuse, clear rhinorrhea. Otherwise, okay. So I think most people would feel reasonably comfortable that we're dealing with a child who's got what we would term, however you want to term it, a viral-induced or a viral-associated wheeze. So now we're going to talk a little bit about the treatment for Jaxxon. So you should all have your poll ready to go. We're going to just talk about first what bronchodilator you're going to use, and how you're going to administer it. So it's active now, so have a look. And I was hoping we'd get some controversy, so... okay. All right, so I'll just give you... Has everyone got in? Because I know on my phone it always seems to take a while to activate. Oh, everything's there now. That's great. Okay, so we have a fairly good majority of people suggesting 6+ via a small spacer as their first treatment. And I'm noting that a couple of people are mentioning nebulizers and other bronchodilators, and we'll come back to that. So don't put your phones down. We're just going to do whether people would use a corticosteroid in this setting. So I've listed you through a few. Okay. Well, I'm interested what the other steroidal doses that people are putting down. We'll come back to that. All right. There's a spread, and I think that'll be interesting to explore that in a little bit more. But I'll come back. Okay. All right. So we can see there is a little bit, particularly when we're talking about steroids, there's quite a lot of variation and potentially some confusion among all of us about what we should be using, and I'm including myself in that confusion. So let's talk about the disease burden first. So children who wheeze, 50% of children who will wheeze before they turn 6. In general, that's the sort of prevalence of the disease. And the vast majority of children, up to about 25% of children aged up to their second birthday will have had, or second or third birthday will have had a wheezy episode, and some children will wheeze recurrently. There's a significant cost associated with these management of these children who are presenting to their, often to their GPs or emergency departments, and often needing admission, sometimes management by paediatricians as well. And some evidence has suggested that it actually drains about 0.15% of the National Health Service's budget is managing children who are wheezing in the preschool age group. So it's a good deal of money that's been spent on children wheezing. This is a difficult slide, and this is a difficult concept, and I'm going to spend a little bit of time talking about this. There are a couple of different phenotypes on children who are wheezing in their preschool age group. Typically, as I mentioned before, bronchiolitis, a child who gets a virus, who starts to wheeze, who's under 1, has got bronchiolitis, and the underlying mechanism is inflammation. An older child in their preschool group who tends to get recurrent episodes of wheezing, which may be associated with a virus or other things such as allergy or exercise or smoking exposure, presents primarily with bronchospasm. And if you looked at the bronchial lavages of those children, they primarily have an eosinophilic reaction, so it's an allergic sort of type response. In the episodic viral infections that you see in children who have viral-induced wheeze, if you take bronchial lavages from those children, their response is similar to the bronchiolitic babies, is they have a neutrophilic response. So it's not clearly the same, it's clearly a different disease. However, these children, in fact, may start off having episodic phenotype of their wheeze, but then the second or third time that they get a wheeze, they actually may have switched over phenotypes into the multi-trigger type of phenotypes. And there's lots of different ways of describing the phenotypes of children presenting with wheeze. So this is just one model, but it is a model that I think helps to understand that there is a difference that we're often dealing with in the slightly younger age group, the 1 to 3 year olds, in comparison to the slightly older preschool age group. And the problem we have with this slightly episodic group is that they can have some bronchospasm, but they may also have some inflammation as well, and they may not be as receptive to the therapies that we want to use for managing this type of condition. Okay, so well, I've looked at a lot of literature trying to prepare for this talk, but also to understand what we should be doing for these children, and just starting off first with the bronchodilator, and I'm actually quite excited that a few people wanted to use nebulizers in my study, in the poll we just did. So this review looked at a lot of different pieces of evidence. It's looked at the management of wheeze right up to the age of 18, but they did drill down and look into children who were 0 to 3 years of age, and they've determined that with their systematic review that children who younger than 3 should receive their bronchodilator via a metered dose inhaler with a spacer, a small spacer. And that there is, when you compare them with the children who receive their bronchodilator by a nebulizer, that there's actually a 44% reduction in admission rate. So the children are getting better exposure to the bronchodilator by having their puffers given to them by puffers and spacers. And there's more distress associated with children receiving their bronchodilator via a nebulizer. They have a persistent tachycardia, which is out of keeping with their respiratory function. And I know that in some particularly mixed departments, it's actually difficult to actually have the stock for puffers and spacers for a range of children, but I'm just putting it out there that you actually may be saving money by not having the equipment, but you actually may be admitting more children because you haven't got the equipment to manage them. The other therapies that I thought were relevant in this age group that we were looking at, that was looked at in this review, was also the use of magnesium. And I know I'm in the world of magnesium inhaled. There are some centres in Australia that use inhaled magnesium, but the evidence is not strong, and they certainly didn't recommend it in this review. I think it's an area that possibly has some opportunities for further expansion. And the use of anticholinergics, which really seems to have settled into a reasonably comfortable space that is used in the more severe children. One of my bugbears in when I'm trying to manage children with wheeze is that we actually don't have objective measures of what we're dealing with in these children. So we actually don't know whether that child I'm looking at is the same as that child that Damien's looking after, because although we do at their observations, there's no one actually saying, well, that child's wheeze is worse than that child. Mark Little did a survey of clinician practice in the Peruki group and demonstrated that the vast majority of practitioners do not do peak expiratory flows in children, and in fact in the paediatric tertiary centres, most places don't actually have peak flow meters. I don't have one in my department. So it's something that we haven't embraced. So what are the other ways of objectively assessing wheeze? Well, there's about 36 different asthma wheeze scoring systems in the literature. Many of them have been used for lots of research projects and validated in those settings. But among the Australasian tertiary paediatric departments, our department's the only one who even talks about a wheeze severity score, which is this one that we use here for the preschool age group, which is based on the asthma severity score. And we use it at times, and when it's used, I find it useful that people can say to me when they arrive they had a wheeze severity score of 6, and now they've got a wheeze severity score of 3. I get the feeling that they're heading in the right direction. So I think this is one of the things that we as PEM clinicians need to actually think about trying to improve. Okay, let's talk about steroids. Whether or not to use steroids in this setting is controversial. And why does it matter? Well, we don't want to use steroids unnecessarily in children. There are significant side effects in the recurrent doses of steroids that our children are receiving all the time, not just in the emergency departments, but also by GPs or when they come into hospital. The side effects include behaviour, they don't sleep, it affects their bones, it affects their growth, it affects their adrenal gland, a whole lot of things that are actually just generally bad for you. So we don't want to use it unnecessarily. However, in the setting of wheezy children who may be in fact an undertreated asthma that we don't really know what's happening, if they actually do have undertreated asthma, they actually are getting airway remodelling from chronic inflammation, and that potentially leads a child on to getting chronic lung disease, and then are consequences for them which could be lifelong. So it's very important that we actually try and make sure that we can justify when we are wanting to use steroids and not. So I've had a look at a lot of literature about the use of steroids, and I found this paper back in 1990, which is quite a long time ago, probably before a lot of you were born, but where they used some methyl prednisolone in the emergency department for children for infants and toddlers with wheeze, and then sent them home, which is, I don't think, something we do nowadays. We don't seem to send many children home with it. But so I don't want to talk about that one because I don't think it adds much to us now in our world. This study in 2003 looked at children who were aged from 6 months to 35 months, so in the lower preschool age group, with viral-induced wheeze. And it was a randomised placebo-controlled trial on using oral prednisolone 2 milligram per kilo for 3 days versus placebo. Now, one of the problems with this study is that it overlaps this condition that we've talked about, bronchiolitis, where we don't want to give them steroids, and we really just want to stop doing things to them. So, and this is a problem that we have with a lot of the studies that have looked at steroids versus no steroids. They showed a decrease in severity and a decreased length of stay in this particular study. So there's a few other studies, but I'm just picking out a couple of interesting ones. The Panica study, which was came from the UK, was published in 2009, and this was a study that they looked at children with viral-induced wheeze being admitted to a paediatric unit, and they were aged 10 months to 5 years. 55% of the children were under 2 years of age. And they were relatively mild disease, but they showed no benefit from doses of steroid appropriate to their age. So I was involved in a study which was published in 2018, and I talked about it last year, so I'm not going to spend a lot of time on it, but we looked at the use of prednisolone in preschool children aged 2 years to their 6th birthday and randomised them to receive prednisolone versus placebo, and we had some discussion about that study and the issues yesterday. So there were some tricky bits associated with the analysis of it, but what we did show was that children were in hospital longer than 4 hours, that there was a statistically significant reduction in their length of stay by 3 hours. And the children who were most affected were those who were more severe at presentation, so Wheeze severity scores 5 and above, or who had limited improvement after initial salbutamol therapy or known previous asthma. But watch this space. There's another study about to come out, published from the New Zealand group, and there's a keen interest in people who like this area to undertake a meta-analysis, and I think this is where we're going to go to try and actually get some further clarity for you and for me about what to do about this in this population. There's a lot of reviews that are published on an ongoing basis from the respiratory paediatricians as well as from the emergency physicians in this area. I think the message that I want you to take home is that we shouldn't be giving steroids to children who are at home to be given to them by parents. There's no evidence that reduces the frequency of their attacks, the recurrence rate, and it just encourages probably more doses of steroids being given to them. We shouldn't be giving steroids to children who are well enough with their wheeze to go home, and we should consider using steroids if they're coming into hospital. Just a quick note, because people were pretty excited about dexamethasone yesterday, and I'm just saying, if you have capacity to get access to dexamethasone, there is definitely a couple of really good studies that suggest that dexamethasone is a suitable option to give to children who have wheeze, and if you want to give steroids, that it certainly may help you, particularly in the difficult child who won't take oral medications easily, and so you can give 1 dose of oral dexamethasone. Not every place can get hold of a dexamethasone solution commercially. I just want to run through a couple of other therapies. Azithromycin is the drug that fixes everything, but it doesn't have any role in the management of acute viral-induced wheeze. Montelukast, again, is a drug that we use not in the for the recurrent wheezes, but not in the setting of acute viral-induced wheeze. Inhaled corticosteroids also has a role in the recurrent wheezer, but is not useful in the child who is acutely wheezing. I've mentioned inhaled magnesium. I think there's area of interest for us to work through. Ipratropium in the setting of more severe wheezing, and intravenous therapies are really for the more severe cases, and we've discussed that their outcomes therapies that we need to be investigated as a whole spectrum of research that need to be worked on in the next few years. So just finishing off with Jaxxon, how would I manage him? Because that's what Damien wanted me to say. I would give him his 6 puffs, a small spacer. I would check to make sure after he'd finished that first lot that he'd had a good response. If his chest was clear after that first one, I would just leave him alone for an hour. I'd come back and see how he was. And if his chest remains clear and his work of breathing is improved, I would not give him any steroids. I would send him home with written Wheeze management plan with education to the parents how to administer the puffers and a GB letter to be reviewed in a couple of days. Good safety netting around that. However, if Jaxxon, after his first lot of puffers, had some response but not cleared his chest like the previous time, I would give him 2 further bursts of salbutamol over the next 40 minutes, so essentially three doses over an hour, and then go back and review him after that period of time. And if he remains wheezy, but I'm happy that he's actually progressing and getting better, I would actually admit him to our short stay unit and stretch out his salbutamol for a few hours and add in some oral prednisolone, because he's going to be in hospital for more than 4 hours and I'm going to try and get him home a bit faster. But what would I do if Jaxxon was only 15 months old? And in this setting, I would change my practice. I would expect that he's going to stop responding to the salbutamol. I think he will respond a bit, and then we'll find that he won't respond as much as he was at the beginning. But I'm not going to give him steroids. I'm going to make sure that he's got good supportive care, that he's comfortable and he's hydrating, and if he needs oxygen, he gets oxygen, but he's unlikely to be needing that. And then I'm going to let him go home. Again, I'd admit him to my short stay unit, but I'd let him go home once I'm happy that his work of breathing has improved. And I've gone over time, so I'm going to show you that this is as clear as mud.
Thank you very much, Meredith. There were some really good lessons in there about Wheeze. We have a question from Becky.
It's yours.
I feel uncomfortable asking my own question, but so I work in a mixed ED, and a lot of our ED is staffed by just like adult ED regs, and they'll often just tell me to prescribe pred. In those kids where you're not sure they're going to stretch to 3 hours, but you think they might, but
Hold off.
so it's worth arguing with the adult regs.
Yeah, I think it's reasonable to just say we've got some time. At this stage, this child, with a bit more intensive therapy, you might get them home without actually having to institute steroids. So I would hold off in that setting. But if they really, every hour when you go back and they're looking like they need more therapy, then I might say, well, they're going to have to stay longer. Then I would start thinking about steroids.
There's a
I have another question from the panel.
Oh.
I've got a question I've always wanted to ask about your study. I'm interested in the second and third day if you do give steroids, because what struck me in your study was that the children who were given placebo, remind me, just correct me if I'm wrong, versus those who were given 3 days of steroids, there was a difference over that first 24 hours, but there wasn't much of a difference over day 2 or 3, which made me wonder whether day 2 or 3 of steroids has any impact at all.
Yeah, no. That's fine. There's actually not very much evidence. That's why I put up all that big number of different regimes. And in fact, there isn't evidence for 3 days of prednisolone. Maybe we could just give 1 day, or just the 1 day of dexamethasone. And I think dexamethasone is actually making a bit of a push for taking over the world. But no, but I don't think our study we weren't, set up to actually be able to prove that. But it is a valid point.
Thank you. I'm not going to let the panel hog all the questions. So does anyone from the audience have, and I think we now have a roving mic. Thank you very much, Katie Barnes.
Hello, Stuart.
Meredith, Stuart Loina from Melbourne.
Thank you.
2.5-year-old Jaxxon, who comes in not hypoxic, not working that hard, with a wheezy chest. If he attended his GP, I'd be quite happy for his GP to give him some treatment if he responded, go home with advice to say, use this maybe 4 times a day, here are the things to come back for. Why do we treat Jaxxon, keep him for an hour, see he's getting better, if he's not getting better, keep him in hospital for longer? Why don't we just accept Jaxxon can go home and be wheezy for a few days?
I think I actually had a slide earlier in one of my versions where I actually said when is it okay to send a wheezy child home? And I think this is a really valid point, because if I'd seen him in a general practice, I probably would have just done exactly what you said. And I think it's partly because it's sort of outside of our normal way of practicing. It's also slightly parental expectation, and particularly if they've come in frequently, they'll expect to be managed for a period of time. I think we have to get more comfortable with being able to say you can go home and you can come back. It would depend, I guess, if they had the capacity to come back easily, so if they don't have transport or have social issues, then perhaps it's better to keep them. I guess I painted him a little bit better than we probably would have sent him home, to be fair, right at the beginning.
Great, thanks. We've got a question from Twitter.
We've got a few questions, but
Okay.
David Stinton has asked, anecdotally, at least for most of us feel ipratropium works and use it. How severe are the cases that we should be reserving Atrovent for?
Tend to use it in children who are at the higher end of our, the Wheeze severity score. So sort of like moderately severe. One of the problems with ipratropium, we did a study years ago about ipratropium, and what the problem with it is that when you give it to a small child in the inhaled form, it tastes disgusting. So you can have a completely cooperative child who's happy to take their puffer of salbutamol, and then you give them ipratropium and it tastes disgusting. So every time the nurse goes back to give them their next dose of salbutamol, they scream and carry on because it is horrible. So I think we need an indication to. So it's a child who is responding but a bit slow, who I'm starting to think, I might need to talk to Sarah and her team about this child rather than me managing it. So I certainly think it has a role, but just be aware the taste is not nice.
That's really interesting. I've never tasted ipratropium before.
Well, I don't eat it either, but you talk to your nurses and they will tell you that please don't order it because the child won't like me after that.
Okay, thank you. I think we're going to move on to our final speaker.